First of all, thank you very much for the opportunity to be here with you. It's mainly to Apollo Hospitals for organizing and invitation, and also thanks to Metatel that I think during the organization we could actually meet together and see in this other world. Let me briefly just try to think from the, let's say, European perspective. I'm actually from Czech Republic, which is a relatively very small country, just 10 million inhabitants, and also my company is much smaller than most of the others. So just let me try to make a small perspective on how IT technologies could be helpful, and telemedicine mainly could be helpful in doing and let's say improving the health. Since let's say the chronic non-communicable diseases represent quite a major factor mainly in Europe, but also in the whole world, let me try to be focused on these. So there will be three parts of the presentation. First, I would like to be focused on some patients. So I'll give you some case studies and show where a focus could be. Then also the methodology and how telemedicine mainly can be helpful in both the early detection but also adoption of some more softer and non-invasive therapies. And third part, I will give you some examples of some existing programs in Europe, but also some cooperation programs as well. Let me first of all choose a patient who is kind of representative of what is happening, or let's say what is an issue and also a challenge and opportunity for telemedicine. Imagine a gentleman who is actually 66 years old. He is a non-smoker and he suffers from diabetes mellitus, second type. He has a light dyslipidemia and corrected hypertension. So basically he seems quite okay. The only thing what is happening is that sometimes he feels some pain in his limb. This is actually a case which we run up in Prague. So it means not a rural area, but quite, let's say, a place with a very good quality of healthcare. The only thing what was happening is that this patient was actually trying to tell his diabetologist that he feels a pain and something is not right. And it took some time. Then after some moments, when actually he really insisted that he needed to have some more treatment and that the situation is probably not normal, he was sent to a program which is run basically by just a nurse in Prague, and he was measured. And at that moment, even though his hypertension was corrected, and let's say all our other parameters seems okay, it was found out that his pulse wave, it means his peripheral perfusion, was not fine. And when he was measured, it was actually found that these parameters were quite critical. So even though he seemed to be almost healthy, he had to be sent for a surgery, actually to avoid the amputation of the left limb. On your left-hand side, you can see the situation before the surgery, where actually he was just measured, and since the pathology, he was also evaluated with imaging method, where it's very clearly seen that on his left limb there was an interruption of the flow, and he had only a peripheral perfusion, or let's say just and not the correct one. So after the substitution, which is on the left-hand side, he was put back, and I think he could become back an active walker. But the trouble here is, and the reason why I show you this is a typical patient in Europe, and this unfortunately happens very often. We have an aging population, we have quite a number of people who suffer from diabetes, and these secondary effects of diabetes and have quite dangerous situation, mainly, this is well known, to the peripheral perfusion. Unfortunately, so far, the system and the medical systems in Europe are so much fragmented that very often this happens. That actually the patient, even though he's diabetic, is conscious and comes to see the doctor, he comes to the situation that even his limb is at risk. It's well known that about 60% of the non-traumatic lower limb amputations in the world are due exactly to this reason. Another case is from rural area. In this case, the rural area is let's say a place which is about 100 kilometers from Prague. But anyway, you are about 30 minutes to the next doctor, and there is a diabetologist, and there's also let's say expert cardiologist, which are about 45 minutes from the place where this gentleman lives. This man is actually 70 years old, he's diabetic, and he suffers, as is seen on the picture, from a very severe peripheral artery disease. Unfortunately, as the same way as the previous gentleman, he was not treated for quite some time, and when he arrived into our program that we have, it was unfortunately too late to make any kind of surgery. So the only way how to save his lower limbs, in this case both of the limbs, because as you see, the arteries are almost non-existing. So we had to put up some kind of combination of physiotherapy together with some intensive medicament therapies, which was very closely monitored in his natural environment. So far, what is good is that he is living, he has both of his legs, and actually the claudication distance, which is the distance he's able to walk, improved from 20 meters to 50 meters. Again, this gentleman was, I think, very conscious. He tried to see doctors, and even though he was not, let's say, in an area which would be economically difficult, just 45 minutes from doctor, just due to the fragmentation, was not treated correctly. That we did a study together with some doctors and centers. We worked together, where we put together almost, let's say, 1,700 patients who were actually coming directly to those centers, and we're trying to see how is the situation. These are mainly patients who are coming from through diabetology, and also who suffered from some kind of symptoms related to their lower limbs. It was not, what we could say, this study was not randomized, because we were just using it in a normal operation. Basically, what I would like to show is, since there is a high percentage of people who suffer from diabetes, that's why also there's a very high percentage of people who actually have some kind of pathology. But the most important group, we actually divided the patients according to the status of their peripheral perfusion. So one group was healthy, and in this case, again, this group is very small compared to normal population, because actually these patients had some symptoms. So then you see that there is a second group, which is border, which is the place, or let's say the status of the disease, where very often the values and the function of the peripheral perfusion can be still reversed. So mainly related to endothelial dysfunction, you are still in a situation where you can bring the perfusion back without a surgery, and you can bring it back to real and less than natural values. Then the third group, the pathological one, which is on the right-hand side, are those patients where really surgery is already needed, and where we try to, let's say, at least minimize the invasiveness of the surgery. But the most important group is the border one, where still you can work, you can avoid surgery, you can avoid, let's say, invasive, or you can avoid also the most massive difficulties and effects for them. And this is, let's say, one of the purposes of this very presentation. Now, as I've told you, I'm from Czech Republic, so some programs we run are in Prague, which is, again, a relatively smaller city compared to yours, just 1 million inhabitants, but still a very good access to the most medical services. The programs that we started and we run in Prague are actually focused first on the early detection and monitoring of patients in order to avoid the secondary effects of mainly diabetes, but also some other chronic diseases, and we are mainly focused there on the vascular and the cardiovascular disease. We also try so that, let's say, thanks to this program, there is an opportunity and also the time window when there is a way how to reverse the illness. So how to apply non-invasive or, let's say, softly invasive therapies. And also, in the meantime, we try to minimize surgeries. And another outcome, actually, which is linked to that, is try to avoid amputation, because still, it's very strange that we live in a time when we have 60% of amputations, non-traumatic amputations worldwide due to this. And I think most of these could be really avoided. In the meantime, we also try to work with technologies where the sensitivity and specificity is over 90%, and these technologies, mainly for the diagnostic side, are only used by the nurses. So it means the doctor himself is not, let's say, he doesn't suffer from the burden of the patients, that are needed to measure, and he only comes in play where actually there is at least the first evaluation. So that's why we can highly increase the impact also for some regions. As for one part is the early detection, the second part is also the monitoring of pharmacodynamic effects. We try to work so that thanks to the monitoring, we can really personalize and improve the outcomes of some pharmacodynamic or some medicines, mainly related to vascular side. In the meantime, there is now a new research program, which thanks to the fact that we can have and see the patients in the early stage, when lots of, let's say, the space and the opportunities for therapies are more open, we also started to work with a clinic that works on cell therapies, where naturally stem cell therapies have much wider applications. But in this case, we are just focused on the endothelium dysfunction and try to make sure that patients, even though, let's say, it is, let's say, microinvasive, that still they can have a better outcomes and they can reverse. It's true that so far, this is kind of research project. A part of working in major cities in Europe, we also have some cooperation in Brazil. And now let me show you this. This is it's one of the oldest rural hospitals in Brazil. It's in southern part of Rio Grande do Sul, not far away from the border of Argentina and Uruguay. And the people who are there, I think that there's a very nice team, but unfortunately, this area is a place which has a very high incidence of diabetes, and unfortunately also a very high incidence of amputations, of lower limb amputations, which are related to that. It's mainly due to the fact that this is an area where tobacco is actually, where there are lots of plants of tobacco, and there's high tobacco consumption, and in the meantime, high meat consumption. So these two factors are probably two of the most important ones. Just to give you some examples of the patients that we had there in this program, first of them, or one of the first patients, is a lady. She's 74 years old, and she suffers more than 25 years of diabetes. So based on that, one can say that she has quite high risk factors. But in the meantime, when she was measured, surprisingly, her, let's say, peripheral perfusion, where we use the pulse wave evaluation, was almost perfect. Let's say the age, her vascular age, would be somewhere on the level of 40 years. And let's say a good lesson that one can also learn from rural areas is that this lady, when she was asked if she does any kind of therapy or what did she do during her life, she said that she's just walking about 15 to 20 kilometers a day in her fields, which proves that actually walking is probably one of the most natural and convenient therapy in this way. Second patient, which is unfortunately slightly different as a case, is a typical from the region. It's a male, 52 years old. He's a smoker, and he didn't know much about his health status. He just somehow felt that he wanted to come for the program because he started to be afraid. And when you just have a look, just visually, he had a very different and already very altered pulse wave. So it means that his peripheral perfusion was already in a non-reversible stage. So he is not too far away, unfortunately, from a surgery. And this is unfortunately the case. And still, I think the advantage is that the patient came at least in time. So it means that maybe in a couple of years, he could be in a situation of amputation. Now he still has a chance to change. As every program is always based on a team, and I think what is very nice in rural areas is that the teams are integrated. And I would say that this is the great advantage of countries like India or Brazil, that I think people come together. And in this case, let's say the diabetologist, the cardiologist, the nurse, all people are together because they try to serve the given region, which I believe is a very important and key asset for that. In this case, actually, this very program is very much helped by one of the Meditel members, Adolfo Sparenberg, who's actually the second from the left, the cardiologist who's leading that. This is just the place, just to feel it's very simple. Basically, I show it here because some patients are measured in Brazil, and since there is not immediately a doctor available, they send the data and we evaluate it in Europe and send it back to them. But in the meantime, there's also some learning and helping so that the local doctors can participate on the program as well. Let me summarize. I truly believe that telemedicine is a great mean for helping to be much more effective in the early detection and monitoring of patients, which can lead to improvement mainly in the chronic non-communicable diseases. In the meantime, also telemedicine opens the way so that, let's say, softer and more modern therapies could be used, because we just use the opportunity window and do it in time. And in the meantime, I think it's a great thing which brings people together, where in the telemedical programs, quite often cardiologists and angiologists or others are together and are not separated. Thank you very much for attention.